I'm Todd Neal with MedPage Today at the American College of Cardiology meeting in Chicago. I'm speaking with Dr. Michael Kutcher of Wake Forest University about percutaneous coronary intervention at centers with and without on-site surgical backup. Dr. Kutcher, can you tell me a little bit about your study?
This was a study that was looking at data from the National Cardiovascular Data Registry. This is a large prospective database that is sponsored by the American College of Cardiology and the Society for Coronary Angiography and Interventions. What we did was we analyzed patients who had angioplasty at sites that did not have surgery on site, compared those with sites that did have cardiac surgery on site. Of the off-site programs, there were 2,029 patients from 61 sites, and we compared that with 299,132 patients at 404 centers that did have surgery on site, and looked at immediate outcomes. The primary endpoint was mortality. Another primary endpoint was the incidence of emergency surgery.
And what were your findings?
Our findings were that off-site programs had similar incidence of emergency surgery, around 0.3% compared to on-site programs, that the mortality with emergency surgery, although high, as we've seen in other studies, it was around 13%. It was pretty much the same for both centers, whether the program had surgery on-site or off-site. And with risk-adjusted mortality, we saw that there was no incidence of increased death in patients who had angioplasty at off-site centers, whether the angioplasty was done globally or whether it was done for primary PCI for acute ST elevation MI, or whether it was done for non-primary ST elevation MI. And we also saw no incidence of increased mortality in patients at off-site centers that did not require emergency surgery. There was an increased risk-adjusted incidence of emergency surgery in the on-site programs, as probably would be expected, since these institutions would be more likely to send a patient to emergency surgery since the surgery is on-site. The reassuring thing is that there was no increased mortality in patients who did not have emergency surgery at off-site centers.
And what kind of regulation is there for off-site PCI programs?
An off-site PCI program really should be developed for the right reasons. There are guidelines that have been set by the American Heart Association, ACC, Society of Coronary Angiography Interventions, based on 205 guidelines. There's also a position paper by the Society of Coronary Angiography and Interventions. If you're going to start an off-site program without surgical backup on-site and do angioplasty, it really should be for the right reasons. The primary reason is to provide primary PCI for acute ST elevation MI, as it's been shown that primary PCI is superior to thrombolytic therapy when you're dealing with ST segment elevation MI. The target volume to shoot for would be 36 primary PCIs per year. Once that's established, then an institution may decide to do elective angioplasties if they're carefully selected, and the volume there should be at least 200 annual PCIs a year after an appropriate startup time. There should be provisions very carefully set in place of transfer of the patient to an off-site surgical center in the event that angioplasty fails and the patient requires emergency surgery. There should be a very clear-cut mechanism of how the patient will be transported, who the receiving center is, and most of these sites that really operate with high efficiency have this planned way ahead of time before they do the procedure, let the off-surgery site alerted that they're going to be doing procedures. The transfer time should be less than 90 minutes, and there should be every provision for patient safety.
And what's the take-home message?
The take-home message is that of those sites that submitted data to the NCDR, there were 61 sites. They had a systems process where they evaluated outcomes, and I think by the fact of collecting data, they had a very rigorous mechanism of organization and logistics. So their findings in our study were favorable for off-site programs, but this should not be taken as a carte blanche for other sites to develop a program. These results might not be comparable if you don't submit to these very high quality requirements. We do not intend this paper to encourage off-site development of angioplasty programs widespread across the country, but what this study does confirm is in the existing programs that have been dedicated to quality, both clinical, operator, and institutional, that they can do angioplasty safely with surgery off-site, only if they submit to these very high stringent criteria.
Thank you, Doctor. I'm Todd Neal, MedPage Today.